Still record. All right. Well, we'll go ahead and start, everyone. This is our eighth consecutive health talk, and the topic of this one is incentives in healthcare. And I want to start off by telling a story about perverse incentives. For one, this goes all the way back to 1902 in the capital city of Hanoi, Vietnam, and it's this up and coming city was wanting to be, I guess, to invite more money into the city and more people for growth, and they decided to they needed some Western technology such as toilets. So what did they do? They went to construct about a 9 mile sewer system inside the city. It was great. They had running water, toilets. They were living a high life until they realized that they inadvertently created a breeding ground for rodents, for rats. So now they had 9 miles of breeding ground for rats, and these rats were running all over the streets. They were biting people. They were getting plague. They were turning into a disaster. So the government thought they were going to be innovative and pay the citizens to go kill the rats. So they were paying like a penny per rat. Well, in a few months, that was great. They started killing rats, but then it got to be too much because in one given day, there was a record of over 20,000 rats being killed and brought to the government's front doorsteps. So the government quickly said, whoa, 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 whoa. Okay, you're killing rats, but we don't know what to do with these piles of rats. So they decided to be real innovative and instead tell everybody, stop bringing us these rats, just kill them and cut the tail off and bring us the tail. We'll give you credit just for the tail. So everything's great, right? They don't have to deal with a big pile of rats and the rats are still being killed. But a couple months later, the government officials started venturing outside of town and started noticing something very strange. Of course, rats running around with no tails. But it turns out that these rat killers, they were just chopping the rats' tails off, getting credit for them, and putting the rats back in the sewer system so they can go breed, populate, and have more rats so they can chop their tails off, get credit for them, and the whole process repeats again. There was even records of people bringing rats in from outside the city so they could chop their tails off. They even had rat breeding grounds outside the city to just for one purpose, just to breed rats and cut their tails off. It got absolutely insane. And of course, a few months after that, the bubonic plague broke out and killed about 236 people. So that's a good story of perverse incentives, and that's called. I think it's called the Hanoi Rat Massacre of 1902, but it goes by a couple different names. So you got a Cobra effect, the same situation. The government was trying to pay people to kill cobras. Well, they just started raising cobras, and there's plenty of stories about how people are motivated for money to do things that might not necessarily be the best thing to do in terms for the society. Um, so if you think about that, just human psychology of being rewarded to do things, and you bring that to healthcare and start looking at, of course, fee for service when people are paid to do things that might not necessarily be best for the patient. Uh, there's this one particular economic law, it's Goodhart's law, is it says when the measurement becomes the goal, it ceases to become a good measurement. And I think that's where we're at now is our measurement for healthcare in terms of the financial, our CPT codes and DRG codes have become the goal. So the more of these procedures you can do, the more you can get paid. And we've seen that over the past 20 years, stents or all kind of different procedures you can possibly do. People realize that, hey, I can make a lot of money doing this. Why don't we just open up a new wing and start driving people into this particular facility just so we can get paid to do it? And it's equivalent to me of chopping that tail off and not actually killing the problem. Because right now we're getting paid or people are incentivized or getting paid to keep people sick in a way versus to keep them healthy. Nobody's getting paid to keep them healthy because there's no structure in place to get paid to do so. So I think that's where we're at now. And I think a lot of people do understand that fee for service is broken and that we have to have some value-based mechanism of payment. How we do that, nobody really fully understands exactly how to do that. There's been a couple things in the works, but how do you accurately measure the outcome of that procedure? And now, John, you can probably attest to this. There's ratings and reviews for doctors. They get better payment based on their based on their reviews from their patients and all kind of mess that doesn't contribute back to the good of the patient and the good of society. So that's where we're at now with coming up with new incentive models. And I think that's where blockchain technology does it. It allows us to incentivize the proper things. It allows us to incentivize everybody that's participating in the network to do good, to focus on their own self-interests. And by focusing on their own self-interest, it also aligns everyone to the greater good. So that's, and of course, that is what we're developing now. With Humanta, with Metaplex, all that, with our Medit API, all that's tying back in to incentivize healthy behaviors, to incentivize to find the cheapest procedure, to perform that procedure and try to have the best outcomes. So there's a lot of incentivization techniques that we're trying to incorporate. And that's really the topic of this talk, kind of just get some brainstorming ideas going and talk about different aspects of, everybody has some unique backgrounds. Connor, I know you've got a lot of incentives in the employer workforce as far as incentive programs. John, you've probably been a part of a lot of that. And Megan, I know talked a lot about Nudge, that particular book with chock full of incentives, motivation. So I'm just going to open it up. Anybody has any comments, wants to add to this?
I'll start. I think what you touched on, we've lived in a volume-based reimbursement system for 70 years. And what we're talking about now is value-based, but it's more than one approach. Excuse me, to value-based. CMS has an approach to value-based, but it's really convoluted. It still involves a lot of metrics, a lot of click and radio buttons, all the things that electronic medical records require. The value-based that we think, or certainly I think, adds more to it is you pay for, as you said earlier, Brennan, pay for staying healthy. So not only does the individual get rewarded for staying healthy, but the provider, I hate that word, the doctor gets rewarded for keeping patients healthy. And how does that occur? It occurs by, as you mentioned also, this direct patient care model, which basically individuals or employers on behalf of individuals pay up front for a prescribed set of services through a direct patient care physician. And there is no insurance involved. That's really the part and parcel of how the volume-based care got started, is through insurance. And I mean, it's a value extractive situation with insurance companies, with the EMR companies. There's no value added by these organizations, with the exception of doctors see them as valuable to some point because that's how they get paid. Now, as the number of physicians that are employed by hospitals, health systems, insurers continues to grow, it's not the physician that gets paid directly from this volume-based. Their employer gets paid, and the physician typically gets a salary and perhaps a bonus based on quality and performance, volume, again, volume of patients seen, depending, volume of procedures performed. That's part of that perverse incentive. So the way to simplify the whole thing is to look at a value-based system that rewards both the individual and the physician for being healthy and providing that safety net, if you will, through a catastrophic indemnity product, which we used to have. You remember years ago, it was Blue Cross and Blue Shield. Blue Shield was for the doctor. Blue Cross was for the hospital, essentially, or the place of service. So we need to get back to part of that anyway, at least the Blue Shield part. If not the Blue Shield part, I think really the Blue Cross. We've got that catastrophic product, that major medical plan that people can buy separately. Thanks to Obamacare, they're not available anymore. There's an attempt being made right now with these association health plans to bring some of that back, but that remains to be seen. But again, you nailed it. The incentives for decades have been very perverse. Doctors don't get paid to keep people healthy. They get paid to treat patients when they're sick. And it's got to stop because it's actually absolutely bankrupting the country.
I want to echo on what you just said there. If you can see my screen, this chart, I'm sure we've all seen this chart. Can you see that chart? Is that the right screen?
Yes.
Yeah. Okay. I feel like I'm the only one screaming this, but everybody says, what happened around 1980? We just started getting off track. Well, there's been a lot of research done as far as economic standing in the 70s and added to a lot of this, but I keep coming back to the actual implementation of the CPT codes and DRGs. Now, Medicare, they made this, or not Medicare, CMS, or the HC, Healthcare Financing Administration, they actually made this law where you had to use these codes to build Medicare in 1983, and Medicaid followed in 1986. So now, if you think about it, we've created this measurement that became the goal. Doctors like, well, okay, if I need a new boat, I can perform X number of procedures and get paid. So, if you think about it, we created a game. We created the medical industrial complex, but we created this a federally mandated blueprint for printing money. It's really what happened. And I don't think doctors went into this. I mean, I think that over time, it's just been almost ingrained in us, and it's trained us to look at things like an input-output type thing. We do this for this patient, we get paid, versus where we're at in terms of looking at the patient as a whole and say, well, how do we keep the patient out of the hospital? Like, there's just nothing in place to provide the payment to anybody for that. So I just want to keep hammering home on that point, because I'm gonna write a blog post about it, because I think there's a lot of merit in that 1982, 1983 space where we kind of got off track. Anyway, I just wanted to share that.
Yeah, that was a long time ago too, if you think about it. I mean, we're going on 36 years of this same system. I mean, there's virtually, we haven't moved the needle hardly at all. And I think that's why it's so relevant right now, what we're talking about today. It's because we do need different incentives, and we do need more choices in healthcare. And, to echo too, just, the book Nudge, we love the book. I have it right here. We highly recommend this book if you are in healthcare. It is by Richard Thaler and Cass Sunstein. Please go out and get a copy of this, because it really does explain a lot about what we are already doing, and how we can even further incentivize healthcare. But it really is one of the leading books. I have to shout out to Joe Babian with Healthcare Leader, because he is the mentor and the one who did recommend this book to all of us. So thank you to him. But basically what we're looking at is choice architecture. And we're already doing this. We don't really realize, but we already are choice architects. It's just that nobody really has labeled it as such. But doctors are, when they describe different treatments that are available to their patients. They can go ahead and guide them to perhaps making a good choice in their medical care when it comes to different cancer treatments, or just how to perhaps get better with their like a surgery that they may need, or physical therapy. They line up these choices for their patients, so that would be defined as a choice architect. Of course too, with Connor, employer benefit. They are choice architects when they design their plans, when they design these things. We'll have Connor speak to that with his expertise. But what the problem is why do we need help in this arena? Is because humans, we're not really good at making decisions. We don't have an infinite amount of information available to us. So therefore, we need to be nudged. We need some help, and we need help making those decisions. So therefore, with the book, we need to nudge people towards making the best choice that's available, without limiting choices, or without over incentivizing people. It's like, hey, if we give you $500,000, to stop eating donuts and drinking soda, of course, I think a lot of people would put down the donuts and the diet soda. But that's not a choice architect. almost to it. It's because we're pushing people past the brink. So when we're going to give an incentive, it needs to be something that is, something that will benefit, but not really like, push people way over the edge. So with that too, just a little bit what we want to do here at Citizen Health, we think we've kind of designed kind of the perfect nudge ecosystem, if you will. There are 3 parts to what we would like to do here with our upcoming Humantive app, our Citizen Health plans, and then of course our Metaplex. So we think with the Humantive app, where you hook up your wearables or your trackers or even your phone, you can go ahead and get rewarded for that activity. Right now, Apple and Fitbit, they're already doing this. They send you the notifications as to how you're doing during the day, remind you to stand up, remind you to breathe. But you are incentivized almost to ignore them if you want to. If you get busy, if something else takes precedence, you really don't have to, it's like, oh, well, I'll stand up later. I'll stand up in another hour. Now with Humantive, we want to say, no, stand up now, go take those extra steps, go walk. Don't ignore your notifications, because now you're forfeiting some merit. You're forfeiting something that is incentivizing you and to maintain your health and then be used towards your healthcare. So there's more incentive here to just be more active, be more healthy. And that leads into the Citizen Health plans, because the Meta, of course, can nudge you to paying for some of your healthcare as our health plans are released. We're hoping sometime in the beginning of next year. But that all builds into this account where you could take care of yourself and pay for your healthcare services, pay for maybe participating in different partnerships that we'll bring on board. And on top of it, that leads us into the Metaplex. So you can buy these services and bundle them right there. So right there, you've got all the choices that you need. We're not limiting, we're helping you choose. And, and we're systematically designing this to be something much better. And that is currently available. And that's all the reasons really get excited about what we're doing here, because it's that perfect nudge ecosystem. But Connor, you've experienced this firsthand by designing your benefits. You've experienced, people who all of a sudden you design these wellness programs, you design different things. So tell us about that. Tell us how people kind of all of a sudden kind of fall into it, and others influence each other, and other people go ahead and get on board with this, because you definitely are a choice architect.
Yeah, so I mean, we've worked with multiple different types of wellness plans, and when any employer is, on the hook for a lot of this money that's being spent on their health plans, they're always looking for incentives to get their employees to be healthier, get them to be more engaged in the consumer process of their healthcare. And a lot of things have not worked over the years, and a lot of things have worked. So, I mean, it's, finding those things that do work is finding those nudges that tries to get people out of their own way from, really, trying to get them to see what might not be immediately in front of them, right? They're not necessarily right on time. The incentive is not necessarily right after what they get, right? I mean, we've found that, you can give somebody $30 a month back on their health plan, which would equate to $360 a year. They'd rather have the $25 gift card in their hand today. I mean, it's crazy. They'd rather have, 25 or 50 bucks today than they would have $360 on the year. But, we found that to be true. So to me, how that really ties into Humantive and the reward and the incentive system is that is this transaction is, fueled by blockchain and, and acted by blockchain to where these meta are rewarded to you, almost automatically. I mean, from a timing standpoint, I mean, that seems to be something to me that's a very exciting opportunity. But, the wellness plans over the years have really shown that if broad spectrum wellness doesn't work. just like you said, I mean, yeah, if we pay somebody $500,000 to quit eating donuts, sure, that'll work. But if you just try to broad spectrum a wellness plan onto a group of employers that are maybe 250, 300, 400, 500 people, the people that are going to use it are the people that are already going to the gym, that are already eating healthy. They're going to take advantage of it, right? Not the people that really need to take advantage of it. So therefore, we kind of design our things that are very targeted based off of, biometric screenings and data analysis at the end of the year. And, we target the people that need it, right? That need these opportunities, that need the nudges. I mean, the people that are already going to the gym, they don't need a nudge. The people that are already, eating healthy and doing the right things, they don't need it. It's that targeted piece that really is, what we have found to be very successful. And then, helping other people see the success stories throughout the company, then you start seeing that chain effect. Then you start seeing that domino effect come down. It's like, well, if Joe can do it, well, surely I can, right? And they see that success and they see the opportunities, and they just kind of realize that, okay, if I need to lose 30 pounds, it's not going to happen tomorrow. But like the actions that I take today affect that 30 pounds in next 3 months or 6 months, whatever it might be. And so they see the results from that, from, better healthcare, less healthcare, less sick care that were there. And then, you tie this into Metaplex with an employer group, then it's just now you're helping to enable these people truly become a consumer, which is so hard to do. It's hard for me to do. So I feel like I know how to navigate the healthcare system probably as well as anyone. But I mean, it's hard for me at times because it's just hard. How do you find them? If you're a common person on the street, how do you find the doctor? How do you find the right price? How do you find transparent opportunity? Just can't. So, I mean, when you tie it all in together, I think that's what really brings this whole thing in together for employers as well as individuals.
Connor, you mentioned one time before that employers have some type of kind of a game, if you will, based on their wearable data. And you mentioned they just have a rudimentary whiteboard. They just write the scores up there.
Sure. Yeah. I've got a group, and then we kind of came up with this together. And I've had a very engaged owner of a company who wanted to help his company be more healthy. He didn't care as much about the money that came along with it as much as he was like, I just want to help my employees. I'm a healthy individual. I want them to be healthier. The soft dollar savings that he gets from it. He goes, that's secondary to just being a helpful employer. And so what he did was he was like, well, I'm going to get, most people have wearables. These people that didn't, that were in this office, got them wearables. Now he just keeps like a top 10 scoreboard right now who, that just, you want to be on that top 10. And at the end of each month, if you're on that top 10, there's a small reward for it. The top 3 is a little bit greater reward. And, and there's 85 employees at this company. So it's not just super easy to be in the top 10. So he gathers their data. If you want to be a part of this, he gathers their data, manually, essentially right now, and just writes it up on the board, walks, activity, and all that good stuff. And it's like the chain and the domino effect that it's had, the chain reaction for that company is amazing. They've got stories of 70 pound weight loss in 7 months. They've got people quitting smoking. They've got gym, a lot more higher gym activity. So just that community involvement of being a part of something that's going on, the safety that it's like, hey, I'm not going to get made fun of by this guy if I start eating salads every day for lunch. When this is a blue collar work environment with it's a lot of construction type employees. I mean, there's some office employees, but the majority of their employee base is blue collar, the construction worker, the welder, the steel erector. And those guys, those are the guys that don't want to be made fun of by Jim that is, about if he eats a salad for lunch or if he skips lunch to go work out, that's, and so by creating that community and that safe place for this opportunity, I think it's really just taking it to that next level to where everybody's participating. I mean, obviously some more than others, but it's really the highest percentage of engagement I've seen so far. And essentially, he just made it a game. With small rewards, the rewards are not large. So it's been pretty cool to see. I can't hear anything. I'm sorry, I can't hear anything.
I think Brendan's muted.
Brendan is on mute, yeah.
Yeah, Brendan, you're muted.
That could be.
I'm glad it wasn't just me.
My hearing's gone.
Yeah. Connor, from all the employers you've seen, is this a common thing? The majority of them have some type of game or leaderboard where they do track this stuff?
No, I mean, there's been efforts. Companies typically try to do something like this, but like a Biggest Loser challenge but unless there's some kind of involvement of, I really found it's got to come from the top down, right? If it's like a group of employees that get together, 10 people, I mean, yeah, there may be success in that little smaller group, but from an employee, from a company-wide standpoint, to see engagement like this, it's got to be, they've got to be bought in, they've got to be engaged, and they got to have some help to put it together because they don't know exactly how to do it, right? So, and they don't necessarily understand the value in it always, other than, making employees healthy. So there are a lot of soft dollar costs in it. I mean, there's a lot of hard dollar costs in it as well. So, I mean, the value that they see, coming back from it has been tremendous. But yeah, no, I mean, there's been a lot of employers that have tried different types of wellness plans, most of which are broad spectrum, kind of slap it on everybody and hope that it works out. And it just usually doesn't. They pay for some expensive thing, and there's very little ROI in it. It's from the company standpoint. And then if there's no ROI, you're not getting any true health, productivity out of it as well. So
I do see us kind of tailoring Humanta to maybe pilot with some employers to offer them just a simple dashboard. It's not a whiteboard, but they can just have a customized employer page, URL, off of Citizen Health or whatever, and they just go and you see a leaderboard of where everybody's at. I mean, just a simple leaderboard, and it kind of serves the same purpose of having that whiteboard out there. Everybody can see it as public knowledge. So you're kind of held accountable if you're not on that list, or if you are on the top of the list, you want to stay on top of it. So you're motivated to do more. So I do see us moving in that direction in terms of working with or providing an employer benefit to an employee or employers based on that front. I think that's a really good opportunity, just something simple that they can easily connect. I mean, within a minute, they can have it going. That's the idea. So let me see here. We got about another 10 minutes, but I'm just going to sum up what we are doing with Humanta. And I know, Megan, you mentioned, well, you didn't mention it, but I'll mention it now. We have a beta program that is opening up next week. I don't know the exact date, but if you follow us on Twitter, we'll be releasing that out, that URL where you can sign up and become a beta tester for Humanta. Pretty simple steps. All you got to do is download our app. It's going to be in the Google Play Store and the iOS App Store. You download the app, you connect your wearable of your choosing, then you pick a personal health journey, and then you go on your daily activities. And if you increase your daily activities and you get more sleep and you do healthy things, you can earn more Meta. And then that is our cryptocurrency, our rewards token. And then later on down the road with this app, it's going to turn into your personal health record where you can get paid to use your data. You can start formulating a holistic view of your health at a given point in time and over time. And you can take your data with you. It's not going to be locked up in EHRs anymore. So it's a multi-phased approach for this particular app. We're going to start easy. So it's going to be fun. We're going to pay you to go walk. We're going to pay you to get proper sleep and go take the stairs versus elevator. So we invite anybody that wants to participate in this to look out for that link and follow up with us beforehand if you want to know more. But other than that, like I said, it will be ready for sign up next week. All right, everyone. Megan, do you have anything else to add? Anyone? Yeah.
No, just that we continue these conversations. They are on Thursdays. I think we are thinking about maybe switching more of the time to during the day, but we'll let you know. But they happen twice monthly. And all are welcome to come, especially too, we love the patient perspective, doctors, of course, partnerships, but anybody who just wants to see a change in healthcare, anybody who believes that, there should be a strong relationship between the doctor and the patient, and just enabling that relationship. That's what we're all about. We love DPC, and we just want to provide better health, wellness, and healthcare for all. It's national, but it's also incentive. So please tell people about us, tell people about Citizen Health, Humantiv, and come get involved with us, because we want your voice. We need your voice, and we're a very welcoming, open, transparent community.
All right. Well, thank you all, and have a happy 4th of July.
Happy Independence Day.
Happy Independence Day, everybody.
Bye-bye.